Well, good afternoon, everyone, and welcome to the July issue of the NRTRC monthly webinar. My name is Bob Wolverton. I'm Program Director of NRTRC, and I thank you for joining us today, and I hope you have a good time with our webinar. Before we go on, I'd like to suggest that you join us for our next webinar, which will be in September. We've had to cancel our August webinar because all the staff will be on an airplane at the time that's scheduled, and it's really hard to do from there. It'll be September 22nd with Allison Lindauer. Those of you who went to our conference last March in Seattle will remember Allison's report on some preliminary data she had on using telehealth for Alzheimer's care. She's hoping to have some finalized data and give you a better idea of what she's found as far as telehealth and Alzheimer's go. But it was extremely positive at the time, and I'm sure it's just going to continue to get better. Also, speaking of conferences, we have our 6th annual telemedicine conference coming up in April in Seattle again, and that will be themed Next Generation Healthcare, Optimizing Your Telehealth Programs. And the information for that is on our website. There's a lot of stuff on our website, so please take a look and join us in Seattle. Now I'd like to introduce Cheryl Skiffington. Cheryl has been working in healthcare for 40 years. Most of it was in Alaska, where they see a lot of patients via telemedicine. Well, we've heard about that at NRTRC. She traveled around the state teaching providers and staffed the ins and outs of telemedicine coding, billing, and documentation. She also taught coding and billing at Charter College in Anchorage and worked for many years as a revenue cycle consultant. Cheryl is currently the interim chief financial officer of Columbia County Health in Dayton, Washington. I'm sorry, I get my W's mixed up. And Columbia County Health is including a critical access hospital, a long-term care facility, and 2 rural health clinics. Cheryl lives in Dayton with her husband, Greg, and her golden retriever, Barkley. Well, Cheryl, thanks for joining us today, and take it away.
Well, hi, everyone. As Bob said, I've been working for a long time with telemedicine coding and billing and documentation, and so I hope to be able to give you a little insight into how all of this is intended to work. So basically, I want to start out with just from a coding and billing standpoint, telemedicine is a mode of delivery. So we really want people to think of a telemedicine encounter as the same as if it were face-to-face. The main thing that we have to do is alert the payer that the visit happened through video conferencing or asynchronous store and forward transmission. We do that by using a modifier, which I'll talk a little bit more about. So, you know, I don't think there's an actual dictionary that spells this out perfectly. Different organizations think of these terms differently. When I started out with this, it was just telemedicine. But telemedicine refers to clinical services that are provided when distance separates the patient and the provider. Telehealth tends to refer to the broad array of applications that promote that delivery. So a couple of terms that you want to get used to is that the patient is located at the originating site and the consultant is at the distant site. And you do always have to have a patient in the encounter. I used to do a lot of auditing for telemedicine visits, and sometimes a provider will contact another provider to follow up on an original visit and the patient isn't actually there, and that isn't billable. You do need to have a patient. So I'm sure you're all familiar with this if you have telemedicine programs, but live interactive communication is synchronous right now or through video conferencing, and then store and forward, which some of you are able to bill for, some not, is the asynchronous recorded some type of physiologic data that is viewed at a later date. And then there's remote patient monitoring as well. So getting into the reimbursement side, CMS was actually on the, kind of at the beginning of all of this reimbursement stuff many years ago. They were paying for store and forward, and still are store and forward in Washington and Alaska because of a telehealth project. And they were also paying for live interactive across the country. So they really were at the forefront. And according to CMS, there has to be an originating site. So this is for your Medicare beneficiaries when you're billing Medicare. It has to be a physician or practitioner office. And so what that means is it has to be a practitioner that Medicare recognizes. So in Alaska, they have a unique provider type called community health aides. Medicare does not recognize a community health aide as a provider, so therefore a community health aide clinic is not a recognized original site. Additionally, hospitals, critical access hospitals, rural health clinics, FQHCs, skilled nursing facilities, all these are eligible originating sites according to CMS. Additionally, you have to be in a rural health professional shortage area or an MSA. So, who does Medicare think or CMS think are distant site providers? So that would be the consultant. And again, this is going to typically be providers who are credentialed with Medicare. So physicians, nurse practitioners, PAs, nurse midwives, all of these providers. And just, I don't know, maybe 5 or 6 years ago, they added dietitians or nutrition professionals, which works out really well for those types of visits. So I want to give you some examples of how this works from a documentation standpoint. If you have a live interactive session, and an example would be if you had an established patient who presents to the clinic with a knee injury. So the provider sees the patient, obtains an x-ray, and documents in the record an expanded problem-focused history, expanded problem-focused exam, medical decision-making of low complexity. So for those of you who know anything about coding, this face-to-face visit meets the criteria for a level 3 99213 office visit, and it's regardless of what you do with it after that. Regardless of whether you get a telemedicine consult, regardless of whether you get them an appointment with a face-to-face consultant next week. So it doesn't matter what you do with this particular visit, you're still going to bill this normally. Telemedicine didn't change that part of the visit, okay? So also, again, for those of you who know about coding, we use modifiers to let the payer know that telemedicine visits are occurring. And you don't have to use a telemedicine modifier on this end of the visit because this telemedicine didn't affect this visit at all. So the x-ray of the knee is inconclusive since there is a lot of edema. So the provider wants a consultation with an orthopedic surgeon. So there happens to be one, which isn't always the case, as you probably know, 35 miles away, who happens to be able to see the patient right now. So we're connecting with this surgeon via video conferencing, okay? So this consultant, this orthopedic surgeon, is watching the patient over video conferencing and asks the patient who's sitting on the edge of an exam table to move his knee in different directions. So he's trying to gauge range of motion. So he's given the history, and he documents on his end in his electronic health record a problem-focused history, problem-focused examination, and straightforward medical decision-making. So this happens to not be a Medicare patient. And so this visit meets the criteria of a 99241 office consultation. This visit happened because of telemedicine. And so you have to let the payer know that you didn't have the patient in the office face-to-face with that provider. So you do have to use the GT modifier to alert the payer that the patient was not face-to-face. Additionally, when you use this modifier, you're certifying that the patient was located at an eligible originating site. Okay, so that's kind of a responsibility then of that consultant. So, not that I want to turn this into a coding training, but Medicare does not cover consultation codes anymore. So if this had been a Medicare recipient, the same components of the visit that were documented, the different levels of history, exam, and medical decision-making, would also meet the criteria for a 99201 office visit, which is assuming that this is a new patient to the surgeon, because CPT codes designate new patients versus established patients. So another scenario with a live interactive session would be, and probably maybe a more likely scenario, is that that orthopedic surgeon would not be available at the same time that you're hoping he's going to be available when you have the patient in your office. So many times you have to have the patient come back to connect to the surgeon at a time that's convenient for them. So in that case, you can bill a presenter. So, and again, this has got to be a billable provider. So if you're going to have an RN, a registered nurse, present this patient, and you typically don't bill RN visits, then they're not going to be billable in this case either. So it has to be a billable provider. So in this scenario, I'm going to say it's the same provider who saw the patient originally. And basically, they're bringing the patient in, they're setting them in front of the video conferencing equipment, they're introducing the patient to the consultant, maybe giving them the history and exam, but they're not actually treating the patient today. So they've already done their exam, they've already done their history, and their medical decision-making was to get a surgeon involved for a consult. So none of that's happening today, but it's a billable visit as a 99211 or a level 1 office visit. So, you know, and that only happens in a live session. You wouldn't have a presenter in a store and forward case. So this 99211 should be appended with the GT modifier, because this visit didn't happen without telemedicine. So even though the patient is face-to-face, it is a direct result of a telemedicine consultation. So again, as I said earlier, Medicare doesn't cover the range of CPT consultation codes 99241 to 99245 or 251 to 255. So instead use the E&M codes 99201 through 99205, 99211 through 99215. And always remember the 3 R's of consultation when you're doing the documentation for the consultant and the surgeon side. And that is that you need to document who is requesting the consult. You need to render your opinion, and you should be sending a report back to the requesting provider. So Now I'm going to give you an example of store and forward for those of you who can do store and forward. And I know that Alaska can, and I understand that Washington has passed the law, but it doesn't go into effect until next year. So the beauty of store and forward really is that you don't have to have a consultant available right away. The consultant can view the record at his or her convenience. So let's say, and I'm going to give you an example of teledermatology because it actually does work really well with store and forward technology. So an established patient presents to the clinic with a rash on the right forearm. The provider is unable to identify the etiology of the rash. So again, the provider who has the patient in the clinic at the originating site is documenting a problem-focused history, problem-focused examinations, and straightforward medical decision-making, which in this case is deciding that a consult is needed. So just like with the live interactive session, this face-to-face visit with the patient is billable, and the provider takes 3 images of the rash and emails them along with the visit notes and a request for consultation via secure transmission to a dermatology practice. So this face-to-face visit meets the criteria for a level 2 office visit, which is CPT code 99212. And again, this is regardless of telemedicine. This visit happened, it's documented, doesn't need a telemedicine modifier. You just do everything just like you normally would. It's a standalone visit. So the dermatologist opens up his email the next day and he reviews the images and the visit notes provided and documents a problem-focused history, problem-focused exam, and the exam in a store and forward situation is I reviewed the images, I reviewed the, whatever you sent, any type of recorded physiologic data. That's how you fulfill the exam component of the E&M code, the Evaluation and Management Code, is I reviewed the images, I reviewed whatever information was sent. He has straightforward medical decision making, and this visit meets the criteria of a level 1 99241 consultation. And this part of the visit at the distance site did not happen without telemedicine. And so you do need to use, in this case, the GQ modifier, which is for store and forward. So the GT modifier is for live interactive, GQ is for store and forward. So what this means, I'm kind of assuming a lot that you know a lot about coding. So on the claim form, the CPT code is used, and then the modifier is kind of attached to it. So modifiers are used to provide additional information to a CPT or a HCPCS code. Again, as I said earlier, you have to have a patient, and it might seem kind of funny that I'm saying that, but I have seen situations where providers started emailing each other about a patient that was seen, a week ago or 2 weeks ago, and they're doing a follow-up, but you do have to have a patient. So again, as I've been talking about modifiers, you want to make sure that you use a modifier on the side of the visit that happens because of telemedicine. So again, the GT is for live interactive, GQ is for asynchronous. So I think I've covered that already. So another code that you might not be aware of is, it's actually a HCPCS code. So Money codes are either CPT codes or HCPCS codes. Two different code sets, but basically the same thing. It's where the money is attached to on your bill. So Q3014 is a telehealth originating site facility fee. And every year, Medicare increases the allowable rate. And currently in calendar year 2016, that amount is $25.10, or 80% of the actual charge. So you're only going to bill this from an authorized originating site. So again, you know, in Alaska is the best example when they have all of these, I don't know, I think it's close to 200 community health aid clinics across the state. Community health aides are not a recognized provider by Medicare, and so you would not ever bill an originating site facility fee on a community health aid clinic. So it has to be a qualified originating site. Obviously, it's not a lot of money, but you know, I think hopefully it does cover some costs. So currently for Medicaid, the states that cover that particular HCPCS code are Idaho, Montana, Oregon, Washington, and Wyoming. So the previous slide was what Medicare covers, and this is what Medicaid covers in these particular states. There's also a telehealth transmission code, T1014, which is a per minute professional services code that's billed separately. So that means you're still going to bill your CPT code for whatever the provider's doing, and this is in addition to that. So both the originating and distant site can bill for a maximum of 90 minutes per day, same recipient, same provider. So you document or you indicate this on the claim form under units. So 1 unit equals 1 minute. Medicare doesn't cover it, and Medicaid is only covering it in Idaho. And you'll find that a lot of private insurances don't cover it either. So those two codes, Q3014 and T1014, are not appended with the GT or GQ modifiers. So you just bill them standard. They are not billed alone. They are billed in addition to your consultation or originating site codes. So states now, there's been a lot of activity, it seems like, over the past 2 years about states enacting parity laws, which is saying that private insurers have to cover telemedicine as if it was a regular visit. So some of the states do have that already: Montana, Oregon, Washington. So Alaska, which is pretty forward thinking, I guess, in telemedicine, does not have a parity law yet. So exclusions to required modifiers would be any accepted practices within an industry. So for instance, teleradiology, you know, that was kind of a system that was already in place. And so many of you, I know at our hospital, we have 100% of our films that are taken here on site are read by radiologists off-site, and we're provided with reports. So you do not have to use telemedicine modifiers for those at all. So also, I'm sorry, you can't see those codes. GO425 is a telehealth consultation in the emergency department or inpatient, typically 30 minutes communicating with the patient via telehealth. This is a problem-focused visit. So in some rural situations, this is going to be a great help. There's also different levels. So G0426 is approximately 50 minutes of consultation. G0427 is approximately 70. So these codes are specifically telemedicine codes. You do want to use the modifier because you have to certify that the patient was located at an originating site, a qualified originating site. Another thing that I wanted to mention is that Washington and Alaska do allow home and school as a qualified originating site. So the difference is going to be that you don't have a billable visit where the patient is located. So you're only going to be billing the consultation. And again, by using the telemedicine modifier, you're certifying that that patient was at a qualified originating site. So I think that finishes up my program. Does anybody have any questions?
Yeah, I'll jump back in here and ask anybody with questions for Cheryl to go ahead and put them in the question and answer pod down at the bottom of your screen. We got plenty of time to answer questions, so you're welcome to go ahead and ask away. And we will get Cheryl's PowerPoint and convert that to PDF and have it available for you from our website. If you have further questions, would like to have some more clarification, don't hesitate to contact us here at NRTRC. And if we can't answer the question, we'll relay it to Cheryl. We have absolutely no hesitation to ask somebody who knows more than we do. So again, questions, go ahead and ask them in the Q&A pod. And while we are doing that, I want to put in the chat pod a link to our survey asking you what you thought about today's webinar and soliciting some suggestions for future webinars. We're here to serve you, and we're here to give you the answers you're looking for. So please let us know what you'd like to hear, and please let us know what you thought of today's presentation. There's a question.
Was it just about the slides?
Yeah. And that's when we'll have them available, and we will, I think we'll be getting a mailing list. We can send them out to everyone, or we can, we'll definitely post them on our website along with the recording of this seminar so you can see it again. Any other questions?
Oh, there's one. So there's a question about mental health telemedicine coding, and do you have anything specific? Or they have, you know, they have some different requirements for mental health and behavioral health. It'd be a good question to send me on the side so that I could send you some information. Can the originating site bill for the professional services for the consulting provider? So are they credentialed with you? If they're credentialed with you and they're within the same state, as far as I know, you can bill for that. So they have to be credentialed with your organization. So I'm assuming that the consulting provider doesn't work for you. So assuming they don't work for you, they have to be credentialed with you in order for you to bill for them. So I hope that answers that question. Is there an originating site visit code and not just the transmission code? The Q3014 is the originating site. So that's the one that was $25 approximately for Medicare, and some of the states cover that at about the same rate. So otherwise, you're going to just bill for what you're doing normally. If the patient is seen by your provider, you're going to just bill normally, and then in addition, you can use the Q3014. There's a question about Skype, and I don't know about the technical security of Skype. Bob, is that?
Yeah, we at NRTRC strongly recommend against using the free Skype because it appears that it is not HIPAA compatible. Now, Skype for Business, which is what Office and Outlook and all that sort of stuff, what Link evolved into, is apparently HIPAA compatible and can be used. But I would be very, very, very cautious about using Skype for a patient encounter in state or out of state.
Okay, there was also a question about RVUs, and I do not have experience with that, but I'm happy to check into it.
Christina, if you want to shoot me an email, I will relay that back to Cheryl, and when she gives an answer, I'll move that back to you.
And then there was another question about mental health transmission. So I don't know, Becky, are you meaning can you do live interactive with mental health? I'm assuming that's what you mean, and it works very well. It works very well indeed, and you just have to make sure that the provider is credentialed to do that. If they're billable in the office, they're billable in telemedicine, but it works very well. I believe that you do have to make sure that you have, you're putting the patient in a room by themselves, and it's a relatively soundproof room, so it's secured. A presenter presents them and then leaves the room. It works very well. Medication management or pharmacologic management, it all works very well with live interactive telemedicine. So I hope I answered your question. I'm thinking that's what you meant. Okay. Okay, so Stacy is asking if there's a visit code as well as the transmission code from the originating site in regards to mental health telemedicine. So if you have if the patient is coming into your office and all you're doing is presenting them to a mental health provider at a distant site, you can bill a presenter at the originating site where the patient is located if that presenter is normally billable. So as I said, if for instance, if you have an RN or a CMA present that patient, they're not normally billable. So you would not be able to bill at the originating site. You would only be able to bill at the distant site where the provider is. So does that answer your question, I hope?
And if I can just jump in, they can still bill the originating site fee, is that right, if it's reimbursed? So the $25, they can bill that one.
Right.
if it's-
Right.
Yeah.
Okay, so that was, okay, good. Okay, I think is that it?
Any other questions? Again, please.
I'm happy to answer any questions after this as well. And if I don't know the answer, I'll check into it.
And you're welcome to forward questions to me through our website or bob@nrtrc.org. And I'll forward the questions on to Cheryl. There are a couple of Medicare documents that I will also send to you when we send out the PDFs of the slides that talk very specifically about what Medicare will cover as far as telemedicine goes, and spells out originating site and distant site requirements. So I'll include a link to that. It's a very good document from CMS. I don't see any further questions. Yeah, Christina has a good, nice compliment for you. Thank you, Christina. If there are no further questions, I will thank you all for joining us. And Cheryl, I will thank you very much for being with us today. I get a lot of questions about billing, and it's nice to actually have someone who knows about the subject to present. So we will undoubtedly be pestering you with questions for a long time to come.
Right.
Everyone, thank you for joining us, and have a great rest of the day.